Today, it is a special day for the Kahlan Nephrology Group meeting. So I'm going to highlight the most important messages from the update of this month, May 2019 Nephrology Update. I'm going to highlight the messages under the following sectors. So I start with obesity and its link with cardiovascular and nephrology, then renal nutrition and metabolic acidosis, and why metabolic acidosis is both with renal nutrition, because there is a link, as I'll demonstrate. Then an important sector, what is new in diabetes, hypertension, and cardiovascular disease. Other clinical nephrology domains, glomerulonephritis, CKD, mineral bone disorders, etc. Few points in acute kidney injury, the update in hemodialysis, and some selected points in the update of renal transplantation. Let me to start with obesity. This is a very interesting review about obesity, kidney dysfunction, hypertension, dealing with mechanistics and mechanistic links. So to start with, obesity is associated with hemodynamics change. So it affects arterial pressure, heart rate, cardiac output, cardiac hypertrophy, diastolic function, and muscle flow, as you see. Increased arterial pressure, increased heart rate, increased cardiac output, increased both eccentric and concentric cardiac hypertrophy, diastolic dysfunction, and disturbance of muscle blood flow. So these are hemodynamics, it changes accompanying obesity. What about hormonal and neural changes? Obesity is associated with increased fasting plasma insulin, decreased insulin sensitivity, increased fasting plasma leptin, increased plasma renin, angiotensin 2, and plasma aldosterone, increased renal sympathetic activity, and increased muscle sympathetic activity, and the reduction of baroreflex sensitivity. This is the accompanying kidney functions in obesity. Increased GFR and hyperfiltration, increased blood flow, increased sodium reabsorption, increased kidney compression, which is, I think it is a new entity that I'm going to explain in this slide. Obesity is associated with increased renal sinus fat. Renal sinus fat can compress thin lobe of Henle and vasa recta, with subsequent increased sodium chloride reabsorption from the ascending limb of lobe of Henle. So sodium chloride reaches macula densa is reduced. The subsequent reduction of sodium chloride reaching macula densa sends a stimulus for afferent vasodilatation. Afferent vasodilatation leads to increased GFR and increased renin secretion. So this is one of the mechanisms that link the obesity with hyperfiltration. Again, visceral obesity is associated with kidney compression, renin angiotensin aldosterone system activation, mineralocorticoid receptor activation, increased sympathetic nervous system activity, metabolic abnormalities, including lipidemia, hyperglycemia, and insulin resistance, endothelial dysfunction, inflammation, lipotoxicity. All these factors can lead to glomerular hyperfiltration, hypertension, and cardiovascular disease. So there's the link between visceral obesity and the cardiovascular system and the kidney, cardiorenal link. Obesity is associated with increased renin, leptin, RAC1, reactive oxygen species, disturbance of cortisol to cortisone ratio. All these factors stimulate mineralocorticoid receptor, leading to increased renal sodium reabsorption and subsequent hypertension. Again, obesity is associated with obstructive sleep apnea, hypoxemia, increased leptin, stimulate chemoreceptor activation, increased melanocortin and melanocortin 4 receptor activation, baroreceptor dysfunction. All these factors that can lead to increased sympathetic nervous system activation and increased blood pressure. So this is the mechanism and the links between obesity and cardiorenal affection. And this may open the horizon for new drugs and new research in the field of management of obesity and associated comorbidities. Let us go to the second sector, renal nutrition and metabolic acidosis. The current issue of diabetes care in May shows 5 articles about nutrition. This is a general position statement or consensus report for nutrition therapy for adults with diabetes or pre-diabetes that is demonstrated in 24 pages. And here just stressing upon low-calorie diet. So even sweeteners, replace sugar sweetened beverages. We are against the cola or other beverages, including sugar, sweetened beverages with water as often as possible. When sugar substitutes are used to reduce overall calorie and carbohydrate intake, people should be counseled to avoid compensating with intake of additional calories from other food sources. So again and again, we should be careful about calories and body weight. Regarding the link of diet and the chronic kidney disease progression, DASH diet. DASH diet is a dietary approach to stop hypertension. All of us are aware by this terminology from since a long time for non-pharmacological treatment of hypertension. So this is the number of patients for each tertile of DASH diet, tertile 1, 2, 3, 4, and 5, according to the score. This is the total score of DASH, and how the score of DASH is done. These are the nutrients in DASH: saturated fat percentage, total fat, protein percent, energy, cholesterol per 1,000 kilocalorie, fiber gram per 1,000 kilocalorie, magnesium, calcium, potassium, and sodium. For each point, we have a target for DASH and the intermediate target. If we achieve the target, each item will be honored 1, score 1. So the total score is 9. And here, if intermediate target is achieved, this is given half score. So this is how we score DASH and DASH intermediate target. Again, the lower the DASH target, so the lower the target for DASH, the higher the relative risk for chronic kidney disease and end-stage kidney disease. And here, if we concentrate on diabetes, the effect of low DASH score is more manifest in diabetic patient. This means to encourage DASH for all, and especially for diabetic person. Dietary approach to stop hypertension, should we embrace it? Yes. Why? Because DASH diet is associated with protection of cardiovascular system through reduction of blood pressure, reduction of uric acid, reduction of urinary lithogenicity, and other factors. All these factors are protective against cardiovascular disease and estimated GFR decline. Regarding plant-based diet, this study included 14,000 middle-aged adults addressing the link between plant-based diets and the incidence of chronic kidney disease. And the link is plant-based diets protect and prevent and reduce the incident chronic kidney disease. This is why we should encourage this style of diet in the early beginning of follow-up of our patients before the advanced stages of CKD, and at this moment we may be afraid of hyperkalemia. Regarding diet rich in vegetables and fruit and the infant CKD, another community-based prospective cohort study including 9,000 study participants. The higher the percentage of fruits and vegetables, the lower the risk of the, as you see here, the highest tertile of fruits and vegetables, the lower the risk of chronic kidney disease. Not only the risk of chronic kidney disease, but also the acid load. The lower the fruits and vegetables, the higher the acid load given to the patient. And this is an interesting point. And this is why I put metabolic acidosis with the renal nutrition, because one of an important armamentarium to manage metabolic acidosis is to take care of the diet we have. The more the fruit and the vegetable, the less the risk of metabolic acidosis. And this is a very interesting figure here. This is a potential renal acid load. Here, these are the diets rich in base and alkali, raisins, spinach, most fruits and vegetables. So we encourage this, fruits and vegetables. And we are against egg yolks and hard and processed cheese, because these cheeses and egg yolks are rich in acid, and they increase acid. And increase acid load increase the risk of acidosis and increase progression of chronic kidney disease as well. So we should take care of what we eat. So if the treatment of metabolic acidosis is complementary between diet and drug, and the available drug, the practical, is sodium bicarbonate. So if we treat metabolic acidosis, we should treat metabolic acidosis, yes. To which target? The sweet spot, the best level of bicarbonate is between 24 to 26. This is sweet spot. Why? Because below this sweet spot, there is increased risk of CKD progression, bone demineralization, skeletal muscle catabolism, and increase the risk of death. And above that, there is increased risk of heart failure, vascular calcification, and risk of death. So we don't like alkalosis, and we don't like acidosis. And the best is to be in following the sweet spot. Serum bicarbonate, sodium bicarbonate is between 24 to 26 millimole per liter. Is there any evidence that fruits and vegetables can be used for treating metabolic acidosis? This is one of the articles, fruit and vegetable treatment of chronic kidney disease related metabolic acidosis. And in this study, we have 3 groups of patients. Patients followed under usual care, patients supplemented by bicarbonate, sodium bicarbonate, and the patient randomized to fruits and vegetables, and urine and serum parameters were tested to be sure that the reduction of acid load is there and the patients are compliant with fruits and vegetables. As you see, both sodium bicarb supplementation and fruits and vegetables are efficient in improving the level of bicarbonate. Both of them correct acidosis, as you see, and both of them, bicarb supplements and fruit and vegetables, are associated with the preservation of chronic kidney disease function and protecting and retarding the progression of CKD in comparison to standard of care. Moreover, if we look at different drugs given to the patient with chronic kidney disease, antihypertensive and other drugs like atorvastatin, here you look at the percentage of decrease. So in unusual care, this is a percentage, but in fruits and vegetables, 69% of the patient reduced antihypertensive drug enalapril. Here, reduced diltiazem. So if you fix this table, you will find the majority of patients run under fruits and vegetables there was a great success for reduction of cardiovascular drugs. This means that fruit and vegetables even have secondary gains after correcting acidosis, is to reduce medications and to protect cardiovascular disease. The question is, if we decide to give sodium bicarbonate, tolerance to sodium in patients with CKD-induced metabolic acidosis, does the accompanying anion matter? This is the title of this commentary in the issue of American Journal of Kidney Disease. We don't like sodium gain in patients in nephrology because sodium gain may be associated with edema, hypertension, and possible heart dysfunction. All of these, we are aware of that. And for many times, we argue that sodium bicarbonate is completely different from sodium chloride. And edema, hypertension, and heart failure are linked to sodium chloride rather than sodium bicarbonate. However, the sodium bicarbonate, at the end of the day, there is sodium balance. And the secret of success of the use of sodium bicarbonate and in the same moment to avoid the risks of excess sodium is to restrict completely sodium chloride in the diet, even to the level of half gram, to this level, 10 to 30 milliequivalent per day. And this is the contrary of the guidelines recommend 90 to 104 milliequivalent per day. So if the patient is very compliant with this very restrictive sodium chloride diet, at this moment only, there is no risk of sodium retention due to the use of sodium bicarbonate. But if the patient even follow the guidelines or doesn't restrict to sodium chloride, there is a risk of sodium retention. I think this is a good answer. And we are waiting the availability of binders for HCl in the stomach without adding salt, and I think this we are waiting the further studies for this drug. Regarding diabetes and hypertension and cardiovascular disease, we are in Ramadan, and this is a holy month for all Muslims. In Canada, this is the position statement from Canadian position statement. As you see, this is the categorization for the patients to fast or not to fast. So from the Canadian point of view, these patients are carry a very high risk and they must not fast. So patients who must not fast are patients poorly controlled with poorly controlled type 1 diabetes, defined as pre-Ramadan A1C above 9%. Patients with severe hypoglycemia within 3 months, recurrent hypoglycemia or an awareness of hypoglycemia, ketoacidosis within 3 months, hyperosmolar hyperglycemic coma within 3 months of Ramadan, acute illness, advanced macrovascular complication, renal disease, the patients on dialysis, stage 4 and 5 CKD, cognitive dysfunction or uncontrolled epilepsy. All these characters meet very high risk. Pregnancy with diabetes or gestational diabetes treated with insulin. So any one of these risk factors means that the patient must not fast. High risk group who shouldn't fast: type 2 diabetes with sustained poor glycemic control, well-controlled type 2 diabetes taking mixed insulin or multiple dosages, pregnancy with type 2 diabetes or gestational diabetes controlled by diet only, stage 3 CKD, performing intensive physical labor, well-controlled type 1 diabetes. All these can be considered as high risk and they shouldn't fast Ramadan. So who can fast? The moderate or low risk who can fast with medical advice and checking plasma glucose are patients who have well-controlled diabetes, treated by lifestyle alone, or with drugs with a low risk of hypoglycemia, like DB4 metformin, DB4 inhibitors, GLP-1 receptor agonists, second generation sulfonylurea, SGLT2 inhibitors, TZDs, or basal insulin in otherwise healthy individual. So this is the position statement regarding the risk for fasting in Ramadan. Again, the change of drug, if the patient is treated with biguanides, DB4 inhibitors, or DB inhibitors and metformin combination, TZDs, all these drugs need no change in the dose. But to take care, as I mentioned in the previous lecture, in the video of the drug and the kidney, regarding sodium glucose cotransporter 2 inhibitors to reduce the dose or hold temporarily prior to fasting. Don't be used with loop diuretics because we are afraid of dehydration. Don't hold those for those with clinical cardiovascular disease. Don't initiate within 4 weeks prior to during fasting Ramadan. GLP-1 receptor agonist, no change if tolerated prior to Ramadan, and you can read all the details of this slide. Regarding insulin, the degludec, detemir, glargine, all these preferred options, but consider reducing the dose by 15 to 30% and to monitor plasma glucose. If there is any risk of hypoglycemia or evident hypoglycemia, fasting should be break. And this is regarding other insulin. Regarding the use of sulfonylureas, long-acting sulfonylurea, it's better to be replaced to other drugs with less risk of hypoglycemia. This is a new member added to sodium glucose cotransporter 2 inhibitor, pixagliflozin, for diabetic kidney disease. For patients with diabetic kidney disease, stage 3A and stage 3B. This means GFR above 30. So it is phase 3, randomized double-blind, placebo-controlled, multi-center, multinational, including 54 investigational sites, United States, Spain, and France, and Japan. And as you see, pixagliflozin is effective in reducing A1C by this in comparison to placebo within different degrees of stage 3AB, stage 3A alone, or stage 3B. In comparison to placebo, it is associated with significant reduction of A1C. In the same moment, it's associated with reduction of body weight, reduction of systolic blood pressure. All these are benefits. And reduction of albuminuria, urine albumin, creatinine is significantly reduced by the use of pixagliflozin. So this is another study after credence that shows sodium glucose transporter may be efficient in chronic kidney disease to target blood pressure, albuminuria, and we are waiting for further applications of this group in these domains of chronic kidney disease. We should be careful about euglycemic diabetic ketoacidosis, especially for patients who will be subjected to surgery. Operations and surgery is a real risk for euglycemic diabetic ketoacidosis. This is why we should stop sodium glucose cotransporter inhibitors before surgery and not to resume sodium glucose cotransporter inhibitor except after to be sure that the patient resume his basal eating style. So all these are risk factors for euglycemic diabetic ketoacidosis, intercurrent illness, fasting, prolonged fasting, and low calories, and others, medication use. Why sodium glucose cotransporter 2 inhibitors lead to euglycemic diabetic ketoacidosis? Why there is a risk for that? Because sodium glucose cotransporter 2 inhibitors lead to glucosuria, and this may lead to this will lead to reduction of insulin and increased glucagon. So a reduction of insulin and increased glucagon, and there is also assumption that sodium glucose cotransporter 2 inhibitor play directly with pancreas and stimulate alpha cell to secrete glucagon. A reduction of insulin and increased glucagon lead to lipolysis and increased ketosis. One important point, glucosuria and the reduction of sodium reabsorption stimulate ketone bodies reabsorption. And the applied point here, if we would like to diagnose euglycemic diabetic ketoacidosis, it's better to think of plasma level of ketone rather than urine, because urine may be misleading. And the statement is, whenever we have patients with unexplained symptoms and the bizarre gastrointestinal symptoms and fatigability, we should order blood gases and not to be delayed in the diagnosis of glycemic diabetic ketoacidosis, because in this moment we give insulin and glucose infusion until ketone disappear. The question is the use of sodium glucose cotransporter 2 inhibitor a safe strategy? Do we recommend them according to the best level of evidence that we have? The benefit exceed the risk, because the benefits are toward the reduction of major adverse cardiovascular events, reduction of cardiovascular mortality, heart failure, CKD, and NAFLD. Be careful about infections. This is why we shouldn't prescribe them in active infection. In the presence of volume depletion, never prescribe them in a patient with dehydration. To be stopped before surgery because the risk of euglycemic diabetic acidosis, especially if we give them with severe depression of insulin with a low C-peptide. There is a risk of bone fracture, for near gangrene. All these are 2BC. TBC means to be confirmed, and amputation with canagliflozin. So there is some risk that necessitate individualization of treatment, and even if we prescribe them, we should follow the patient meticulously. But up to this moment, the benefits exceed risks. And this is the report about 55 cases of Fournier gangrene. And Fournier gangrene is necrotizing fasciitis affecting the perianal areas in males and maybe in females, and it's catastrophic. This is why if we observe any change in the color of the skin in this area, we should put it in consideration for early management to avoid the drastic and dismal prognosis. And this is the report of 55 cases, 21 associated with canagliflozin, 16 with DABA, and 18 with empagliflozin. And we cannot prove causation. It is just weak association to be considered. Regarding hypertension, this is one of interesting, smart, and simple review for hypertension in 22 pages. Here, again and again, the one of important point, we should stress on the lifestyle modification, sodium restriction. If we even follow this modest restriction here, we can achieve a reduction from 2 to 8 millimeter mercury. Weight loss, aerobic exercise, DASH diet, again and again, lifestyle change is very, very crucial for management of hypertension and other cardiovascular disease. What about the target of blood pressure? Do we support intensive control blood pressure? The idea is, yes, we can support. We can say liberally, we would like to intensify blood pressure control, targeting the lower as tolerated by the patient. But in the same moment, because we are aware by the studies that documented reduction of mortality with intensive blood pressure control. However, if acute kidney injury occur with this tight control, mortality increases as shown in this recent article. So the message is to separate the chaff from the wheat. The message is whenever we apply the policy of intensive blood pressure control, we should monitor kidney function. If there is a risk and a tendency for acute kidney injury, we should relax this treatment, because intensive blood pressure control associated with acute kidney injury carries not optimal prognosis and even increased deaths. Especially in diabetic patients, we don't support systolic blood pressure to less than 120 in diabetic patients. Regarding arterial stiffness, this is a risk for heart disease in chronic kidney disease. And here I'd like to present these tables that show the different drugs. So AGS breakers increase ejection fraction, and this is the level of evidence. Antihypertensive drug ACE inhibitors, they reduce arterial stiffness. The evidence is strong in general, and the level of evidence in CKD or kidney transplant is moderate. And this is the ARBs, reduce arterial stiffness. You can look at the different names of the drugs and their effect on arterial stiffness and the ejection fraction and the level of evidence in general and in CKD and transplantation. For immune suppressive drugs, anti-TNF anti-TNF therapies reduce arterial stiffness, and the evidence is strong. Cyclosporin is associated with increased arterial stiffness, and the evidence is modest in general and in CKD and transplantation, while increased arterial stiffness is doubtful. The link between tacrolimus, everolimus, platacept is doubtful. Mycophenolate mofetil is associated with reduction of arterial stiffness. Corticosteroid is associated with higher stiffness, so we can go through. This is an interesting review about this is KDIGO executive conclusions regarding heart failure in chronic kidney disease. As shown in this article, this figure shows different degrees of CKD, stage 5, stage 4, stage 3A and B, and these are the different treatment modalities. So here the strong is the use of beta blocker, carvedilol, and other beta blockers, either to reduce mortality or even to lessen symptoms. So again, if we go to review evidence-based medicine for management of hypertension, I recommend this paper about cardiorenal syndrome. So we have here different degrees of CKD, stage 1 and 2, 3, 4, and 5, and all these are different modalities for management. The best of evidence is toward the use of beta blocker. The evidence of beneficial effect is strong in stage 1 and 2 CKD, is strong in stage 3, and the evidence is moderate beneficial effect in stage 4 and 5. And if you compare it to ACE inhibitor and angiotensin receptor blocker, evidence is the same in stage 1 and 2 and 3, strong, but here ACE inhibitor or ARBs, the evidence is weak in stage 4 and 5, although here the evidence is more better, it is moderate. Again, the ARNI is strong here and strong here, but absent in advanced stages, because ARNI up to this moment are not prescribed, are not advised to be given for patients with estimated GFR below 30 milli per minute. Regarding the nitrates and digoxin, the evidence is weak or absent. This is why we don't like them in chronic kidney disease, especially digoxin. Even in dialysis, I recommend not to be prescribed because we are afraid of toxicity. The evidence for other drugs you can hear, this is the resynchronization and implantable cardioverter. This is the evidence is strong, but here absent and weak in advanced stages, either because the patients included in the studies are low or the evidence is not there. Diuretics are just to remove the congestive symptoms, but they don't improve the prognosis in different stages of chronic kidney disease. This is why the ACE inhibitor, beta blocker, followed by ACE or ARBs, ARNI, mineralocorticoid receptor antagonists also are strong if estimated GFR is above 30 milli per minute. But for nitrates, digoxin, and diuretics, evidence is not there. Other clinical nephrology domains, this is a very smart idea, is to use hydroxychloroquine. Hydroxychloroquine is associated with immune modification, immune modulation through targeting toll-like receptor 4 and others. And this is a double-blind, randomized, placebo-controlled phase 2 clinical trial compared hydroxychloroquine to placebo in patients with IgA nephropathy treated with RAS blockade. As you see, after the second month, fourth month, 6 months, use of hydroxychloroquine is associated with significant reduction of albuminuria. Regarding combined trial, what's combined trial? Through the last years, we are waiting the results of combined trial. This trial in stage 3B and stage 4 CKD is to use nicotinamide, which inhibits phosphorus reabsorption, and lanthanum carbonate, which binds phosphorus. So by this way, we target phosphorus by two different mechanisms, reducing absorption and binding phosphorus by using this combination therapy. And unfortunately, the result of this very nice trial was negative. There was no significant difference between the using combined and others and the placebo, because the problem is tolerability. So the idea is smart, to target phosphorus by binding and reduce absorption, but I think we should search for more tolerated drugs. So this is the number of patients, 200, and this is the assignment to active and the placebo to different degrees. And again, this study left us with more questions than answers, and it was a negative trial. Can we use sevelamer to reduce proteinuria in chronic kidney disease? This is an open label blinded end study, showed that use of sevelamer doesn't add to the RAS blockade in the reduction of albuminuria. So again, this is a negative study. Regarding sodium zirconium cyclosilicate among individuals with hyperkalemia, this is one of interesting binders. We have new binders like this, sodium zirconium cyclosilicate. And this is 12-month phase 3 study, and the other batromere. Both of them are potent to chelate potassium. And this study was fantastic because it allows the use safely the use of RAS blockade without the risk of hyperkalemia. So this is a positive toward encouraging use of the new potassium binders. Vision impairment in chronic kidney disease. This is a very interesting review about this topic. Vision impairment, epidemiology, mechanism, and differential. As you see, the environment of chronic kidney disease and uremia are sharing between CKD and ocular diseases, uremic optic neuropathy, ischemic optic neuropathy, cataract, glaucoma, retinal detachment, all because we have inflammation, oxidative stress, neovascularization. All these factors affect both eye and the kidney. What is this? This is a kidney. Here you can find here blood within the renal tubule. So this is acute kidney injury for patients treated with oral anticoagulant. So we have anticoagulant-related nephropathy, and we should be careful whenever we suspect if there is hematuria without clots combined with acute kidney injury or worsening of non-chronic kidney disease, and the patient is treated with warfarin or other novel anticoagulant drugs, increase in prothrombin or an INR, increase INR above 3, but we shouldn't be rushing in diagnosing anticoagulant-related nephropathy except after excluding the major glomerulonephritis and vasculitis syndrome. Confirm the diagnosis by kidney biopsy, presence of dysmorphic erythrocyte in Bowman space, extensive erythrocyte cast formation in distal nephron segments, acute tubular cell injury with intracytoplasmic tubular ferric iron hemosiderin deposit, absence of endocapillary or extracapillary proliferative glomerulonephritis, other causes of AKI and hematuria in anticoagulated patients to be excluded as well. So again, we shouldn't encourage the use of warfarin for high levels of INR. So if we are using warfarin, it is better not to exceed 3 INR of 3, because this may lead to acute kidney injury on top of chronic kidney disease. What is brusumab? What is this? Here, this is a very interesting study, phase 3 trial for treating X-linked hypophosphatemia. These children are liable to hypophosphatemia and skeletal abnormalities and rickets. Why? Because of increased FGF23. So brusumab, it is a purely human monoclonal antibody against FGF23. And this study shows beneficial effect of the use of brusumab for ameliorating the skeletal manifestations of this syndrome. Let us shift to fluconazole. Fluconazole may work directly on the water channel, leading to reduction of polyuria in patients with nephrogenic diabetes insipidus, here independent on V2 receptor. So it directly stimulates aquaporin and release of aquaporins toward the plasma membrane. So this is a stimulative idea, but before agreeing to use it, this drug is expensive with a side effect profile, but the test is stimulative to find the use of fluconazole for treating nephrogenic diabetes insipidus. Another area for fluconazole, this is a case of nephrocalcinosis with hypercalcemia before any treatment. So hypercalcemia and nephrocalcinosis. After adding hydrochlorothiazide, this is the level of calcium is still high, but after adding fluconazole 50 milligram, calcium is reduced, and it's reduced significantly for the dose of 100 milligram. Why fluconazole reduces the serum calcium in this syndrome? Because it inhibits the 1-alpha hydroxylase. So one of the mechanisms of fluconazole is in reducing hypercalcemia is inhibiting 1-alpha hydroxylase. So it reduces one active vitamin D, so it will reduce intestinal absorption and hypercalcemia in these in this syndrome with mutations, because in these mutations there is inhibition of degradation of active vitamin D. So by the use of fluconazole, because ketoconazole can lead to the same action, but ketoconazole side effect profile is higher than fluconazole, and fluconazole is relatively safer than ketoconazole. So this is another stimulative idea from the recent publication. So fluconazole can be considered as a new therapeutic tool to manage patients with this mutation leading to nephrocalcinosis. What about CKD progression and the use of direct antiviral drugs? Using direct anti-hepatitis C virus drugs were associated with reduction of progression of especially of non-diabetic kidney disease. As you see, this is the level of systemic GFR before, and this is after the use of non-diabetic patients. GFR improves and albuminuria is reduced in non-diabetic patients. So the conclusion, direct acting antiviral therapy for hepatitis C virus infection may slow chronic kidney disease progression, particularly in patients with non-diabetic chronic kidney disease. AKI associated with acute pancreatitis usually is neglected, and mortality, if acute kidney injury accompanied by pancreatitis, mortality increased and exceeds 75%. And this is we have early and late phases. Early, within 24 hours, acute pancreatitis is associated with hypovolemia, hypotension, histamine release from pancreas, activated kallikrein kinin system, increased bradykinin, high prostaglandin A level. And after 24 hours, because of sepsis, increased abdominal pressure, and direct nephrotoxins, all these can work together to cause acute kidney injury. This is why the management, we have initial management, we have management after 24 hours, and after acute kidney injury development. Initially, within the first 24 hours, monitor vital signs and the daily weight of patients with pancreatitis, monitor kidney function well by following serum electrolytes, creatinine, and urine output, treat hemodynamic instability, avoid non-steroidal, administer intravenous ringer lactate. So here, if we use analgesics, we don't use non-steroidal. Administer fluids, IV ringer lactate in emergency department, and the rate depends on acute pancreatitis severity. Start enteral feeding, ICU admission for patients with severe acute pancreatitis. Avoid nephrotoxic agents, ammonium glycosides, vancomycin, amphotericin, and contrast agents. After 24 hours, administer IV fluids as needed, continue enteral feeding, continue to monitor urine output, kidney functions, and electrolytes, avoid prophylactic antibiotics, monitor volume overload, monitor intra-abdominal pressure to avoid abdominal compartmental syndrome, treat infected pancreatic necrosis, surgical intervention when indicated. After that, decrease or stop IV fluids in patients with peripheral edema, pulmonary vascular congestion, increase the abdominal pressure. Consult the nephrology service earlier. The earlier the referral, the better the outcome. Administer diuretics for volume overload and abdominal compartmental syndrome. Decompression surgery for abdominal compartmental syndrome. Kidney replacement therapy, preferably continuous renal replacement therapy when indicated. Adjust drug doses to the level of kidney function used in patients on kidney replacement therapy. Monitor urine output and other signs for recovery of kidney function. So this is the plan of management. Another important point is the quality improvement. We should achieve a better quality for all nephrology services. And this is a very interesting Fisher article about quality improvement for acute kidney injury. We have structure measurement, process measures, outcome measures, access measures, patient experience measures, and balancing measures. So structures measures, a structure of care is a feature of healthy care organization related to the capacity to provide high quality health care. Process measures, a health care related activity performed for on behalf of or by a patient. Outcome measures and outcome care is a state of health of a patient resulting from health care. Access measure, access to care, is the attainment of timely and appropriate health care by patients or in release of a health care organization or clinician. Patient experience measures, experience of care is a patient's or in release report of observations of and participation in health care or any resulting change in their health. Balancing measures, unintended and or wider consequences of the change that can positive or negative. And these are the examples for each one of the quality indicators. So we have these quality indicators, again, structure measures, process, outcome, access, patient experience, and balancing measures. At the end of the day, we should look at the holistic view for acute kidney injury in the community, preventive strategy in the hospital, and even when we use renal replacement therapy, we should optimize so it is a complete circle of improvement of care. So we have to work on population, national monitoring for variation in acute kidney injury incidence, and then high risk population to work for education, following miss medication, imaging, surgery, sick strategy, and this will end in kidney health response for medication adjustment, minimize exposure, message care team, and the patient and monitor. Regarding hemodialysis, we encourage fibers, not only for the general population, but for dialysis patient, for the positive effects of the using of fiber. The upper tertile, the higher the fiber, the lower the cardiovascular, so the lower the cumulative major adverse cardiovascular event-free survival. This means survival is better when we encourage fiber in diet. Use lung ultrasound in hemodialysis. It is a very nice tool, non-invasive assessment of Kerley's beta line. In this study, this is a randomized control study including 35 patients in each arm. And again, if we encourage the lung ultrasound by, this is the active group, lung ultrasound, and this is control group. So here, if we encourage lung ultrasound, this will control Kerley's beta line with subsequent improvement of dry body weight, and in the same moment, the reduction of blood pressure. So the use of lung ultrasound may be complementary to reduce the risk of hypertension in the population of hemodialysis. Should we restrict the use, our evaluation of dialysis adequacy by just the evaluation of single pool KT over V for urea? The answer is no. As you see from this title, it's one song. This means that it is the last dance, the last appearance, the last discussion. The KT over V, it is not good, it's not reliable, it's not valid for women and the patient and the male with a small volume. Fluid overload patients, children, elderly, obese, diabetes, pregnancy, race, preserved renal function. So all these 8 categories of patients, the KT over V is not valid for them. The key message is we shouldn't use only one character. We should use clinical and laboratory parameters with our patients. Regarding potassium, we should monitor potassium well. We don't like hyperkalemia, but in the same moment, hypokalemia is bad. Here, post-dialysis hypokalemia in this large cohort of patients, 3,900 patients, was associated with increased mortality. This is the low range from 1.9 to 2.9, medium range 3 to 3.4, 3.5 to 3.9, 4 to 6.4. As you see, this is the risk of hazards of mortality is higher if we are treating hazard risk of mortality is high in patients with post-dialysis hypokalemia, especially if there is a pre-dialysis hypokalemia. So the worst combination, bad outcome, is linked to pre-dialysis and the post-dialysis hypokalemia. And it seems that post-dialysis hypokalemia affects the outcome in conjunction with pre-dialysis hypokalemia. So we should check potassium, avoiding hypokalemia before and after dialysis. If I ask myself, what is the best cutoff point value of potassium for the best outcome in dialysis patients, the best pre-dialysis potassium is 5 millimole per liter. And then we should take the sake and the help of nutritionist and dietitian to avoid hyper and hypokalemia. And this is the work collected by Dr. Summer from our unit. Here you can find the pre-dialysis potassium, here post-dialysis less than 3.520, and here post-dialysis less than 3.51, and this is the pre-dialysis potassium. So it seems that hypokalemia post-dialysis is present in good fraction of patients in our unit. Regarding testosterone level and frailty, this is very nice. Low testosterone is associated with frailty, as shown, and muscle wasting, as shown from this study. And this stimulates the nephrologist to check serum testosterone level if we have testosterone level, if we have frailty. And this because effect of testosterone deficiency is sarcopenia, reduced lean body mass, and increased reduced body mass, bone mineral density, anemia due to reduced erythropoietin production, depression, and the cognitive impairment. All these are effects of testosterone deficiency, and this is how we find the frailty component: low grip strength, low gait speed, low physical activity exhaustion, and unintentional weight loss. So again and again, we should think of testosterone whenever we have this manifestation, and we may think of supplementation in the presence of evidence of testosterone deficiency. We may use nandrolone decanoate, anabolic androgenic steroid, 100 milligram intramuscular weekly for 6 months, and this is the study showing that the effect was increase in lean body mass, improvement in walking and stair climbing. And this is a study for nandrolone decanoate. Here, increase in lean body mass, increased muscle cross-sectional area. Others, testosterone anabolic, this is 50 milligram transdermic daily for 3 months versus placebo, increased testosterone concentration associated with increased albumin. This is another strategy, testosterone ester. This anabolic androgenic steroid, 250 milligram intramuscular every 2 weeks before hemodialysis versus placebo for 24 weeks. Increase the free testosterone, improve in the total aging male symptom score. Again, testosterone deficiencies may be associated with many symptoms of frailty, and we should put in mind and to measure serum testosterone, and we may think of supplementing these patients by this drug. What is NAION? NAION. NAION in hemodialysis. It is non-arthritic anterior ischemic optic neuropathy. That is, the patient presents with reduction of visual acuity because of intradialytic hypotension. So should be careful about hypotension during dialysis because it may affect the vision. Regarding the last sector, which is transplantation, if we have anemia, anemia is bad, associated with poorer transplant outcome. This is why in this mini review, they discuss the use of erythropoietin and its effect on the immunity in transplanted patient. So using of the EPO reduce the effective T cell, inflammatory T cell, and increase T regulatory cell. So it seems that the use of EPO is friendly with the transplantation. One of the important issues with gastrointestinal symptoms and the link between immune suppressive drugs and gastrointestinal tract. Very interesting review discussing the pharmacokinetics and pharmacodynamics and side effects of the drugs. Here, if you look here, oral ulcers are more common with mTOR inhibitors, maybe with mycophenolate mofetil and tacrolimus, gingival hyperplasia with cyclosporin, nausea and vomiting and dyspepsia with all immune suppressive drugs, gastroparesis with cyclosporin, the pancreatitis with azathioprine and corticosteroid, chronic diarrhea with tacrolimus, mTOR inhibitors, and mycophenolate, constipation with mTOR inhibitors. So all gastrointestinal symptoms can be encountered as risk as side effects of immunosuppressive drugs. And this is the interactions of gastrointestinal targeting drugs and immunosuppressive. The use of proton pump inhibitors affect mycophenolate mofetil, reduce so we should be careful about the use of antacids or proton pump inhibitors with mycophenolate mofetil. The eradication of Helicobacter pylori, especially if it includes clarithromycin, have interactions with the majority of immunosuppressive drugs. Regarding steroids, if the patient, the original kidney disease is glomerulonephritis, should we continue giving steroid, or we may withdraw steroid from these patients? So this is a propensity score matched analysis, shows no adverse effect of early steroid withdrawal in non-diabetic kidney transplant recipients with and without glomerulonephritis. So this is a number of patients included, the large number, 79,000 patients. So this is the patients, 49 patients, recipient with non-glomerulonephritis cause of end-stage kidney disease, 11,000 recipient with early steroid withdrawal, 38 maintained on steroids. For patients with glomerulonephritis, 6,000 patients with early steroid withdrawal, and 23,000 patients maintained on steroids. The prognosis is the same. Survival of the graft is the same between glomerulonephritis and non-glomerulonephritis regarding either keeping or steroid withdrawal. And this study is interesting. Why? If we have tendency for toxicity of steroids and the original kidney disease is glomerulonephritis, we may withdraw corticosteroid based on this analysis. What about ABO incompatible kidney transplantation? Is there a great difference between ABO incompatible and the ABO compatible? This is the one of important sources that's published in May in Lancet, showing that the outcome is poorer in ABO incompatible kidney transplantation. So this systematic review and meta-analysis included 40 eligible studies, including 65,000 patients. All-cause mortality at 1 year in favor of compatible, ABO compatible. 3 years all-cause mortality at 3 years in favor of compatibility. Mortality even at 5 years showing superiority of ABO compatible. So ABO incompatible renal transplantation is associated even after refinement of desensitization with big amount of money. Cost is high. Side effects are there, even mortality are there, so they are very expensive. So this stimulates the nephrologists and the transplanters communities to think of paired exchange donation rather than to indulge in ABO incompatible transplantation. Although ABO incompatible kidney transplantation is still a source for transplantation, because we don't know if we leave the patients on dialysis, is there a real difference or not? Although we have some studies showing a great difference, increased mortality in dialysis, and other study from UK showed no difference. But this systematic review and meta-analysis documented the poorer outcome of ABO incompatible kidney transplantation and constitute a call for encouraging paired donation. And this is graft failure censored, death censored at 3 years in favor of ABO compatible. Regarding aspirin prophylaxis, is a very nice study here published, and here Professor Saad Khamis is one of our great friend and professor of nephrology at Manufia, chaired in this review about pros and cons of aspirin prophylaxis for prevention of cardiovascular events in kidney transplantation and review of evidence. I encourage this article. So this is the kidney transplant recipients in dual antiplatelet needing emergency surgery, hold thiopyridines for 5 days and continue aspirin. Preoperative thiopyridine may be started as early as possible after surgery. Waiting time for kidney transplantation and other elective surgery after PCI, wait for 3 months in case of bare metal stenting, and 6 months for drug-eluted stent. Dose of aspirin, the recommended daily dose for aspirin is 81 milligram, ranged between 75 to 100 milligram for prevention of secondary prophylaxis. Again, here, secondary prophylaxis, but regarding primary prophylaxis, no clear recommendation, and this is why I would like to end with this very recent article published today in the Lancet issue, the coming week, the rise and fall of aspirin in the primary prevention of cardiovascular disease in general, and this figure shows the journey of recommendations of aspirin from the early 2000s up to this moment. Here, this is the consider use of aspirin in adults at risk for coronary artery disease, and then there is change up to Richard 2019 recommend against aspirin in individuals older than 70 because of the risk of bleeding, and provide a weak recommendation, class 2B, that aspirin might be considered among the adult aged 40 to 70. So I think the recommendation, the studies are moving in the stream against the use of primary prevention by using aspirin. I would like to end the presentation. It is quite exhaustive to review even the publications in 1 month in the prestigious journals of nephrology. So I reviewed 337 manuscripts. So we should continue to know and to learn. And this is, I encourage the use of this site. And I'd like to end with this Arabic quotations باللغة العربية. احنا لابد وما أوتيتم من العلم قليلا، ده كلام ما فيش فيه في جدال. وكما قال الشاعر، لما الواحد يقوله غرور كده بالنفس وبالعلم اللي بياخده، قالت النفس بتحدث للواحد كده بتوسوس له، قالت النفس قد علمت كثيرا أو قد علمت كثيرا، قلت هذا الكثير نزع يسير. مش فيها كلام، ده كلام بسيط اللي هنعرفه. تملأ الكوزة غرفة من محيط، كوباية جاي فيها شوية مية، فيشوف نفسه بقى ايه، فيرى أنه المحيط الكبير. يبقى احنا نبقى عارفين ان احنا وما أوتيتم من علم قليلا، وما نعرف هذا الكلام يبقى ما قدمناش حل واحد، ان احنا نستزيد من العلم، نستزيد من العلم كل يوم. كل لحظة تمر علينا لابد نتعلم فيها حاجة جديدة. كل سنة وانتم طيبين، رمضان كريم، ونشوفكم العام القادم، أو نشوفكم إن شاء الله في رمضان القادم، ونشوفكم على طول في رابطة الكلى كل شهر بإذن الله. والسلام عليكم ورحمة الله وبركاته.